Good morning, everyone. I'm Mary Lee Stein, and I am happy to introduce to you our next session. This is an OCR update and 2023 priorities. I'm introducing Melanie Fontes-Rayner, the Director of the Office of Civil Rights of the U.S. Department of Health and Human Services. Welcome, Melanie.
A little bit of a delayed applause there, you guys. Hopefully that's not bad. You guys are just tired. So good morning, everyone. Good to be here with you all. I'm Melanie Fontes-Rayner. I run the Office for Civil Rights at HHS. As many of you know, we're unique to other civil rights offices across the country because in addition to civil rights, which is a lot, we also do HIPAA. This is a map of our offices. Our office does not match the regional offices with HHS. We consolidated a bunch of our regional offices for budget cuts in the past decade. We have 8 regions across the country, and we're in 11 offices across the city, 11 cities across the country. In that space, that means that, for example, we have a Los Angeles office, we have a San Francisco office, Seattle, Denver, Dallas, Chicago, Kansas City, Atlanta, Philadelphia, New York City, and Boston. And so that means in those regions, we have staff on the ground. We have a lot of cyber staff that are national and do a lot of tele is not the right word, remote work, is that what we call it? Or what we used to call it. I go to work 4 days a week. That was a joke, but it's also true. So anyways, we have physical presence in these offices. That means that if you have regional considerations, you have regional events you'd like attended, you have an entity you think it would be really helpful for OCR to come talk to us about something, we'll do it. You'd be surprised the lack of frequency with which local organizations reach out to us. My staff does do smaller provider outreach a lot because we know HIPAA applies to everyone, big and small. And so we spend a lot of time trying to work with smaller and medium-sized covered entities to try to help drive compliance. So again, we'll just start at the priority. These are not things that are new. These are not things that are a secret. We have 2 notice of proposed rulemakings in my shop right now. One is the notice of proposed rulemaking related to reproductive health care privacy and the HIPAA privacy rule. The comment period closed over the summer. We're working on finalizing that now. It's a big priority for the administration and a priority for our office. We're also prioritizing investigations in the space that both drive compliance and in the breach space. So hacking, ransomware, right of access initiative, and risk analysis enforcement initiative, which we'll talk a little bit more about, is a new initiative we're driving. Engaging with healthcare industry on cybersecurity. So we've been putting a lot of information out there. We have a couple YouTube videos. We have a cybersecurity newsletter. We put out guidance pretty regularly, FAQs, documents related to things like plain language. We do webinars and technical assistance. I think more from us in that space on the regional offices now that we're back in the building. And then again, we're looking at the HIPAA security rule, understanding of the changing landscape in the healthcare space and cybersecurity. So we talked a little bit about this on the front end. This is a privacy rule. So the President of the United States has signed, this is weird. I feel like it's either too loud or not loud enough. Thanks for laughing, that one person. So we have a reproductive privacy rule. We did this because we got a lot of questions around the country when the Supreme Court overturned Roe v. Wade. We got a lot of questions about what does this mean? What does this mean for data? Initially, we put out a guidance. That guidance restated what the HIPAA privacy rule already says, which is that there are 8 categories for permissible disclosures. Those you have permission, which means you have some discretion. The only things that HIPAA requires by way of disclosure are 1, to the individual when the individual seeks their information, and 2, to the Secretary of the United States, which has been delegated to the Office for Civil Rights when you have a breach affecting 500 or more people. That's all the statute requires, meaning that there's permissible disclosures. We took this reg a step further to actually prohibit the use and disclosure related to reproductive health care, related to certain types of investigations, in part because what we are seeing, what we are hearing across the country is that women were going to states like a state like California where healthcare is lawful, and then another state, another agency outside of that state was trying to reach in and go after that doctor, that clinic, that patient. When the patient goes home, they're trying to go after that patient when she's at home. And so we've put out guidance. That guidance still stands. It's the current state of the HIPAA privacy rule. We've taken it a step further with this regulation. This is a priority area for us, and one in which we think needs to happen soon because we have a lot of issues in the space, and one in which we're driving. We talked a little bit, oh, did I say them backwards? How do I go backwards? Oh yeah, there we go. So this is the rule. It, again, limits the disclosures. We're reviewing the final comments. Part 2, how many of you have ever heard of Part 2? Nobody. So Part 2 is a substance use disorder program. It's funded by SAMHSA. For a long time, it has had its own statutory restrictions that are separate and apart from HIPAA, which are actually more restrictive than the HIPAA privacy rule, HIPAA security rule. What this has resulted in, so let's take a step back. I understand why, when they created this program, they did this. They wanted to protect against stigmatizing providers, stigmatizing care, and making sure that people felt comfortable going to get that care, and that the only way they would do that is by being very restrictive with how those records were treated, how that data was used. We all know now, right, when we think about substance use disorders, that it's part of behavioral health. Behavioral health needs to be incorporated into primary care, and that care coordination is really important when we think about a holistic approach to a person and substance use disorders. So this was the product of Congress. A bipartisan law was passed in 2021 that said to HHS, go change your regulations so that now the HIPAA protections are brought into Part 2, so they're not as restrictive. This is like one of the top things we hear about from public health officials in states. It's something we hear a lot about from providers just in general as they think about the Part 2 program, and something that we know will be helpful once it's finalized and implemented. And we worked on that with SAMHSA. This is probably the showstopper, right? So the HIPAA web tracking bulletin, we put out a bulletin almost a year ago to date. This bulletin makes very clear that while web tracking applications are really helpful for patient populations and understanding your the people and traffic coming to your websites and your facilities, that you still have to follow HIPAA, and that we still need to make sure there's a business associate agreement in place for authenticated and non-authenticated uses. We have taken it a step further, and we actually sent out letters with the FTC, understanding that we both care a lot about this topic. They have different jurisdiction than we do. We have the HIPAA-covered regulated entities. Those letters went out to those organizations earlier this year, and we're continuing to work on that. We got sued on this last week, so that's that. But we look forward to continuing to educate the public, and we continuing to work on this, and so we'll move on. We talk a little bit about telehealth and privacy. So this was in response to a GAO report. The GAO report said that we should put out some guidance in response to how to both protect HIPAA but do telehealth in a plain language way. We know that sometimes these things are not done in that way, and so they're not accessible to various parts of the population. So I think, again, a very unique area where we think about civil rights, whether it's a person with a disability, a person who's a senior, a person who maybe doesn't have access to a particular type of broadband access. And so we just put this guidance out. Again, not required, but best practices on plain language to make this more accessible for our population across the board. This is something we just like to, again, you know, COVID has changed, right? It's over. But we also know that we learned a lot during this time. So during this time, we like to think about, well, you have all interacted in spaces where you've maybe not seen these steps taken. So how can you have telehealth and protect your privacy? One way in which is to do it in a private location. Strong user passwords, multi-authentication, encryption when available, avoid public Wi-Fi. Another way to do that is audio only, and we have had success with that. That's also a way in which we have been able to, at least in the Medicaid space, promote access to telehealth to communities that otherwise might not have access to telehealth, and working with Medicaid agencies to make sure that they understand how a telehealth only could be HIPAA compliant and be used in a space that could expand access under civil rights laws. So I think this is not a secret. We have seen a growth in the large breach reports filed to our office. The chart on the left is the full duration in which the Office for Civil Rights has had this mandate to implement HIPAA security, HIPAA privacy rules. And you can see the percentage of hacking, the You see that blue, it says theft, right? People used to literally steal paper records. Now you look at the chart just this year alone, it's over 3/4 hacking. Theft is almost non-existent. And then unauthorized access and disclosure. So again, showing you the shift in the landscape that we see right now based off of the reports that are publicly reported to our office, which are public. So you can see why we're shifting our focus to really focus in on hacking and ransomware and really focus on cybersecurity. Again, this shows the large breach reports filed. So back to 2018, you'll see the trend is upward with respect to the large breach reports. I think we anticipate this year will end right about the 700s, consistent with last year. The trend that's very alarming is that red line on the top. That shows you the number of individuals affected by each large breach report. Earlier this year, it was almost double the same point it was. As of June, it was almost double the point it was in the previous year. Again, these numbers are based off of the reports that are filed to HHS. Those numbers can change, right? We might find out it actually was more people, maybe it was less people. However, I think the disturbing fact here is that we're seeing a growth in hacking in the healthcare space in particular. We're seeing growth in ransomware, and we're seeing more and more people be affected by this. So I'd like to focus a little bit on some of the enforcement actions that we've done, because I think that's a good way to show what not to do and how to make sure your organization doesn't end up in a settlement with us. I like to, at the outset, though, remind folks, we got 51,000 complaints last year. Of that, 2/3 were HIPAA. Of those complaints, you didn't see, 30,000, is that right? 30,000 or so, 31,000 or so settlements from us, because oftentimes when we get a complaint, it's resolved with technical assistance or voluntary compliance. I like to remind that to folks because I think sometimes there's a perception that we just really want to be going after organizations and have a getcha. We don't, and we don't impute bad faith. We oftentimes understand, in particular with civil rights and HIPAA, sometimes organizations don't know what is required of them, and sometimes they're so small they don't have the resources to adequately fund and do them. So oftentimes we're resolving these things without you ever seeing them. The ones you see in press releases are typically the ones that are more egregious or the ones in which we couldn't drive voluntary compliance. So here, this is something we're seeing more and more and more of. We had a doctor, a psychiatric practice, where a patient went online and put an online review, I think it was on Yelp, and said something negative about the care that they received in the provider. The provider then responded and disclosed protected health information in response to the Yelp review. Right. That should be obvious to you that that's illegal. But we're seeing it more and more, especially in the dentist space. So it's something that we like to flag. We just had this settlement, not our biggest settlement ever, but I think important to show people that when you are responding to social media, online reviews, disclosing protected health information is not allowed and not careful with respect to the data and security of that data. We recently had a very large settlement with LA Care. LA Care is the largest Medicaid plan, I believe, in the country, and in LA, it's the largest plan affecting millions of lives. They had a large breach that was filed. We investigated. In that investigation, this third bullet here, you'll see these are the potential violations. These are violations we see. If you were to look at my enforcement press releases, we see these over and over and over and over again. In particular, lack of risk analysis. This is why we're now focusing on risk analysis and have a risk analysis initiative nationwide to focus on that. If you don't know what risk you have and you're not managing that risk, you are not doing your job to prevent cyber breach, or impermissible use and disclosure of data. We also know that when you have those things in place, you should be incorporating them throughout your book of business and making sure that even when you have new business practices or you have new ventures, you're updating all policies inclusive of your risk management and risk analysis relative to HIPAA. Again, $1.3 million. We're going to monitor them for 3 years, and they're implementing a corrective action plan. We had this case was our first ransomware case. So the office really is focused on ransomware. It takes a long time to investigate these cases. This is our first ransomware case. It's not a lot of money. It's not a lot of people, but I think it's so important. It was a business associate in the New England office. We investigated them. It turned out in the course of that investigation, based off the large breach, that there was an unauthorized access that occurred back in 2017. The organization had no idea that that was happening until we started to investigate. And in the course of that, again, we found lack of risk analysis, failure to implement regular review of information system, and failure to implement policies to comply with the security rule requirements. So I think more to come in the ransomware space. It's something we're seeing a lot of, but also I think important to flag here, we think this is important to highlight because this is happening more and more in the healthcare space. And overall, HHS is looking into new resources to help with various types of entities that are maybe not a larger hospital system, thinking through more technical assistance through the other side of the house through 405D resources. It's something that's a department-wide priority. You're all familiar with our right of access initiative. This was launched in 2019. We're up to 45 settlements. We think of the HIPAA right of access, meaning you have rights to your information and a timely access with a reasonable fee, that this is a cornerstone right of HIPAA, that many patients want their own records so that they can make determinations and decisions about their own healthcare, and then they control who gets that information. I would say 2 flags in this space. One, this continues to be a large driver of our complaints. Many covered entities still don't follow the law or know that there's a timeline for which they're supposed to return those records. Oftentimes these are resolved with my staff just making a quick phone call and someone saying, oh, because they think it's just their prerogative to go as slow as possible or not to have a practice in place for how to give those records over. And second, as we see more and more advent of applications, third-party applications, where a patient wants to have their records sent to a wellness app or some other application that may or may not have a relationship with the provider, that it's a best practice, A, to remind that patient that once those records go over to that third-party application, unless there's a business associate agreement in place, that those records are no longer protected by HIPAA, meaning that if there's a impermissible use or disclosure or breach, that those records might be volatile and subject to that. And second, that to the extent there should be in place a business associate agreement, we work on writing that business associate agreement. It's not always the case that there should be, but I think having that buyer beware reminder to consumers is really important, especially as we see more and more reach into our health records as well as like web accessibility and thinking about applications on our devices. The risk analysis initiative. See ya. You guys don't think it's like a little distracting when someone leaves, but I'm sure he's just going to the bathroom. Maybe he's like, I'm done with this. But I mean, whatever. I mean, also maybe he has a phone call, so he's probably very important. So the risk analysis initiative is a new initiative we're working on at the Office for Civil Rights. It will focus on compliance with this key requirement, both risk analysis, risk management under the HIPAA security rule. Most of our large breaches, like 99% of them, are lacking a risk analysis. We'll be evaluating those to determine when it's something more egregious versus just a risk analysis violation. This is meant to drive compliance in the industry and something we want to show to the covered entities how important risk analysis, risk management is. And then again, the goal here is better overall data security. So this is just launched. You're the first people we're talking to about it outside of the people that work for me. I think an important initiative and more to come from in this space, but something that we're really hoping that will prompt compliance. So these are just some best practices that we've compiled over the course of our enforcement activities. Review all vendor contract relationships to ensure business associate agreements in place. Make sure that risk analysis, risk management are being updated regularly. This isn't something you do one and done and you never look at again. Oftentimes, we will get a risk analysis. I use quotations marks here, and it'll just literally have a point of contact where in the organization you go for that. There's no plan in place. They're not implementing anything. That's not sufficient. Disclosure of PHI media and paper. We continue to see these, not as much, but we continue to see the case where some janitor puts a box of PHI in an alley. It's discovered sometimes by reporters, but we continue to see these. Obviously, those are impermissible use and disclosures and should be better practices. Lessons learned from incidents and overall security risk management, and then providing training throughout the organization. Hey, Stanley. The high-tech amendment recognized security practices. So you all know that in 2021, Congress signed a law. That law put in place the High-Tech Amendment Act with respect to recognized security practices. It's not required, so we don't enforce upon it, but we do have practices that is taken into consideration when we do our enforcement. It can be a mitigating factor when it comes to civil monetary penalties, compliance, corrective action. We've done a fair amount in this. We have a YouTube video that's been up for a year. It has thousands of views. And so again, a helpful tool that we try to put out there for medium and small size organizations. Cybersecurity Awareness Month was just last month. Woo! And in that space, we did a bunch of stuff. Here's just a couple of the things. We did two guidance documents. We put up a new newsletter. Again, you can sign up for our newsletter. I'll show you the slide at the end where you can sign up for that. We're regularly trying to do these things to try to help covered entities. You should use them. We also did a new video, both in English and Spanish, on, again, regulated entities and defense against cybersecurity, really focusing on the HIPAA security rule. Let's see. And then we're also doing regional engagement across the country. We just updated the security risk assessment tool. This is a tool that you can use online. We understand it might be complicated to determine, am I a regulated entity by OCR? Am I regulated by the NIH? Am I regulated by FDA? Am I an FTC? This is a thing, it's free, it's online. We just updated it in October. You can go in and put characteristics about your organization to help determine which regulations apply to you. It's free. So again, I'll just re-emphasize, this is our HIPAA page. My website is, it looks like a government website from the 90s. It gets updated very regularly, it just looks that way. You can sign up for our listserv here. I think that's helpful because every time we have a new guidance, a new blog post, a new video, a new enforcement action, it goes out on that listserv. And then we're sort of active on Twitter, and so that's another place you can get information. But just encouraging overall, these are ways you can stay in touch with us, and I think we can use some of the tools that we're making available. The last slide is an appendix. We will make sure these get sent around, but these are just all the resources, particularly with ransomware, that we've done in the last couple of years. So I'm going to go ahead and sit down so we can go ahead and do questions. Thanks.
That was great. So now we're gonna kind of shift a little bit, and we're gonna just have a little bit of a conversation. I have some questions. I really appreciated that, especially when we called Stanley out for leaving the room. That was just the best.
Hey, Stanley.
Here. There you go. Okay, so we talked a lot about, or you talked, I didn't talk, I sat here and watched, but you talked a lot about the things like breaches and ransomware. But overall, in cyber attacks, what kinds of trends are you seeing? And among those trends, what can healthcare stakeholders do to better prevent, report, and recover from a cyber attack? It's a big deal right now.
Yeah, so I'll restate the data that we set up there. So there's been a 239% increase in large breaches. Those are mandated, reported to our office. They're public. Anyone can track them. They're on a website. We know that that's growing, and I think consistent with the data this year will be on track to be the same. In that space, there's been almost a 300% increase in ransomware. I think, again, the healthcare space is on the front end of these attacks. You don't always read about them, right? Because sometimes organizations end up paying for them, and they don't want you to read about them. And then I think we get a lot of questions about, well, what does that mean? What is it, like, should I be liable for ransomware? I'm the one being attacked. And I think, all fair questions, right? And we think about this in the sense that it's a fact-specific determination. So a breach under HIPAA is defined as acquisition, access, use, or disclosure of protected health information in a manner not permitted under HIPAA, which compromises the security or privacy. Again, going back to the presentation, within those large breach reports, even in ransomware, we often find lack of risk analysis, lack of risk management. So it's not just that you were subject to a ransomware attack, it's also that you were not compliant with the HIPAA security rule. We have a lot of resources in this space. We put up a fact sheet last year on ransomware and HIPAA. We can send that around. We just did a bunch of listserv updates with respect to not only us, but HHS Cybersecurity Coordination Center, which brings together all of the components within HHS that have sort of an equity in cybersecurity and is more of a proactive space where they're thinking about how do we proactively work with covered entities? They don't call them that because they don't regulate them. How do we work with these hospitals and organizations to make sure they're being compliant and able to take these steps to prevent a cyber attack, right? Because you might have larger systems that have money to go out and have a private law firm or contract this out and then come back and implement that, right? And that's great, that's good for them, but that's not the case with a lot of medium and smaller size organizations, and HIPAA is applicable to all. And then, let me see, we talked a little bit about the settlement up there. I think more to come from us in this space. We have a couple more in the piper right now that I think will be helpful for folks to look at. But again, I'm not telling you anything you don't know. Risk analysis, risk management, lack of training and practices.
All right. And I think all of us either know an organization that has been hit by one or have heard of an organization that's been hit by one. It's really pervasive right now. So how can an audit?
And I'm obviously I work in healthcare, so I'm like more empathetic to healthcare than other industries, right?
Yeah.
But we've seen hospital systems go offline, right?
Yeah.
Which is a problem when you have an emergency department that can no longer see and treat patients, which is why HHS is both thinking about this in our shop, which is policy and law enforcement, but also what proactively can we do? Can we think about this? The president's budget last year had a significant cybersecurity proposal in it. It will have it again this upcoming budget because this is a significant priority, especially in the healthcare community.
Right, and patient care is affected directly when that happens. So how can they use an audit result to assist stakeholders to improve privacy compliance and security or cyber hygiene? That can directly help them.
Yeah, so HHS in 2016, we did a HIPAA audit program, reviewed policies and procedures employed by covered entities. And in that, we conducted audits of 166 covered entities and 41 business associates and notified these organizations of OCR's findings. In 2020, OCR published an industry report to share the overall findings on compliance with the audited provisions of HIPAA. Specifically, the summary found most covered entities met the timeliness requirements for providing breach notification to individuals. Most covered entities that maintained a website about their customer services or benefits satisfied the requirement to prominently post their notice of privacy practices on their website. Most covered entities failed to provide all required content for notice of privacy practices. Most covered entities failed to provide all required content for breach notification to the individuals. Most covered entities failed to properly implement the individual right of access, which we talked about earlier, such as timely access within 30 days and charging reasonable cost-based fees. And then last, most covered entities and business associates failed to implement the HIPAA security requirements for risk analysis and risk management. So we haven't done an audit since then. We know we need to do one. We've been flat funded for over 2 decades. We're working on it. So I think more to come from us in this space, but I think we appreciate that it's helpful. We have this existing report from 2020. While the trends are changing, what we're seeing by way of ransomware and hacking, I would say that the things about risk analysis, risk management continue to be the same.
So what information or what education are you creating, are you disseminating to help the healthcare industry? And as a part 2 of that, how can we help? How can WEDI help disseminate information to the industry as well?
Yeah, so much of my presentation has identified many of these things. We really do try to do a lot in this space, and we're trying to do more because we recognize there's a wide variety in those entities that we regulate in terms of size, funding, what kind of program they're in. And so we talked a little bit about the security risk assessment tool. That's on our website. It's on the FTC's website. It's on the FDA's website. It's on the ONC. Like you have a hard time not finding it. It's free. And it is made so that you can go in and answer questions about your organization to determine regulatory requirements, legal requirements, and guide that process so that you can get a sense of where you might land in the federal government and get more resources. So we just updated that. That's something that we think is a really important tool in making HIPAA more accessible, and something that, it's free. You don't have to pay for it. It's just free. We talked a little bit about our cybersecurity newsletters. We've done these on common cyber attacks such as phishing, exploitation and vulnerabilities, and weak cybersecurity practices, HIPAA security incident procedures. We typically do those at least 4 times a year. Sometimes we do them more. Again, if you sign up for our listserv, you will be able to have them emailed to you when they come out. They're also populated on our HIPAA website fairly regularly. Guidance materials, web tracking is a good example. We got a lot of questions about this. In response, we put up a guidance because we were seeing more and more use of web tracking without compliance in the HIPAA space, and the questions we were getting. Not a new rule, nothing new, just being very clear that what HIPAA, that you could use web tracking, that's great, but you still have to follow HIPAA. And then YouTube videos. So we had one last year that got over 10,000 views. We just put a new one up, I think it was last week, that specifically talks about best practices in the cybersecurity space. And in that space, we did it in English and Spanish for the first time. And I think more to come.
Follow them on YouTube.
Actually, do any of you guys know who Nick Heasters is? That makes you know you haven't watched the video because he's the star of the video. So he was at a hotel and somebody said, hey, you're that guy from that YouTube HIPAA video. That's a true story.
Wow. So I'm gonna, this is kind of coming back to some of the things you've already talked about, where your audits are finding that that entities don't necessarily understand their responsibilities or requirements and obligations under HIPAA. So this seems obvious to me, but is lack of understanding of the rules leading to non-compliance? And assuming the answer is going to be yes, how can we improve compliance?
Yeah, I mean, the answer is yes, right? HIPAA is very complicated, and I travel all over the country. I do stakeholder engagement with all sorts of size organizations. I speak at a lot of conferences, some very lawyerly focused, sometimes it's very hospital and industry focused, sometimes it's tech focused. And I am constantly surprised by the disparity of knowledge people have about what they think HIPAA does and does not do. And literally, I sat in a roundtable once and had a doctor tell me she couldn't share information because somebody died and HIPAA prevented it. And that's just like, that's not accurate, but like that kind of stuff happens all the time. So in this space, we try to focus on areas we see a lot of. One is the right of access initiative. Again, most of our complaints filed with our Office of Civil Rights are so people want their own records, or people filing on behalf of a loved one where they're trying to get a parent or a child's records. We're seeing more and more of this, again, within a reasonable amount of time, 30 days with one 30-day extension and a reasonable fee. This is something that our office had proposed a rule on to further do more stuff on. We haven't finalized that. We're not finalizing that right now. We just don't have the bandwidth to do that. But I will flag at something that is, when people think about their interactions with the healthcare system, people dread going to ask for their medical records. And it's sort of easier now with MyChart and some of these applications where, you can go in, you can mark you want everything coordinated, you can download all your records. But, there's also, like when I left California, I got some of my records from Kaiser. I was not able to do that. I had to go into a Kaiser during COVID. I had to find the 1 hour a week in California, it was California during COVID, to figure out when they were open to get this, to get a CD-ROM of an MRI I had, right? And I think that's very common in this space and how people sort of perceive this as a headache. The other area, is risk analysis, and we talked a bit about that. I can't emphasize enough how important that is. If you don't know your own risk, you're not managing it, then you are not ready for a cyber attack. And those things are taken into consideration when you are investigated in large breach reports. Those are considered throughout our analysis, and so it's really important. It's something we're really focused on. And then recognized security practices, right? So we had new requirements, or I guess they're not requirements, new things that you can do to allow for security consistent with NIST and other laws. And in that space, we definitely take into consideration if an organization has done recognized security practices as a mitigating factor in our investigations. It can lower a civil monetary penalty. It can review for a different corrective action plan. It's something our office takes into consideration when we're doing an investigation.
So, talking about trying to show that you're in compliance, what are the ways that a covered entity can demonstrate to OCR that they are in compliance? What are those recognized security practices that the healthcare industry can employ? You sort of touched on it a little bit, but can you expand on it?
Yeah, I mean, so we don't say what recognized security practices are, right? Recognized security practices include standards, guidelines, best practice. I'm reading this literally from a talking point. Recognized security practices include standards, guidelines, best practices, methodologies, procedures, and processes developed under NIST, the Cybersecurity Act of 2015, and other programs and processes that address cybersecurity and/or statutory authorities. What ends up happening oftentimes in our review is that an organization will just give us boxes of recognized security practices, and then our team takes a very long time to go through those to determine, are they actually mitigating risk in the way that we think a recognized security practice should, or is it just they're handing over a bunch of different things? And we're also seeing in this space a lot of cookie cutter is the wrong word, but like organizations that are saying, this is a recognized security practices, off the shelf, go use it.
We're done.
Yeah, and I think that's a good point, right? Even if, like we don't support or not support those, right? It's your choice to use those, but if you're using them, use them, right? Don't just have it be somewhere so that when you get caught or you get caught in a breach, you're handing it over to OCR. Use those practices in place to make sure you're protecting PHI and you're protecting your systems, right? This should be something that's as regular as updating your systems. When you think about these things, you should be constantly thinking about your HIPAA security rule requirements and how you update your organization.
Right, right. Much of what we do, what we need to do, is driven by enforcement actions. So are there any that you think it would be helpful to discuss with regulated entities, like those that are sitting in the room or on the virtual attendance today?
Yeah, so we talked a little bit about the online review case. I think it's a good flag because it's something we're seeing more in the HIPAA privacy space. Impermissible use and disclosure. It's not something we're just seeing, we see a lot in particular industries like dentists. It is something where we see more and more, whether it's Yelp or what's another review company, like Google?
Well, Google is,
Or
yeah.
even social media, right? We had a case where someone was just responding to something on Facebook, on the person's Facebook page, and also disclosed protected health information. But I think an important reminder that just because you're mad doesn't mean that you get to disclose individual details, and that you're probably better off connecting offline and having that conversation rather than posting it publicly so that that person's record is disclosed forever on the internet, right? And I think it's just a good reminder in general as we think about protected health information and the privacy rule, being mindful of how information is disclosed and being mindful of what information we may be disclosing. We understand that there might be limited situations where people want to talk about the kind of care that they're providing or talk about what they're seeing in their office, but you need to be cognizant of protecting that protected health information and taking steps to protect your patients. And then I think the second is just, we've talked a lot about risk analysis today. I hope you guys leave this and go back to your organizations and evaluate that. But it is a really important thing. The LA Care enforcement action we did just a couple months ago is a big one. We have another big one coming up. I think just reminding that they had this malware on their system since 2017. They didn't discover it until 2018. That happens more and more, or sometimes in the course of our investigation, they'll find various outputs of that, or various outputs where an organization had implanted itself into the system. They don't check the systems regularly, so they didn't know that for years, where this has been in their system for, I think we had one case where, it was like a 2020 action that this organization had been in their system since 2007. That's a long time. And I think people want health information. They know that there's a lot of money in healthcare. They know that they can use this information. And I think just being real with people about how important this is, right? This isn't, even my own building, right? I tell my staff, this isn't 20 years ago. We can't investigate these cases the same way we did we used to get paper faxes and letters mailed to us and sometimes phone calls. Well, now we have a portal where we get thousands and thousands and thousands of complaints, and we have a large breach portal where we separately get another over 1,000 to 2,000 complaints filed. We have to think differently about how we're engaging with covered entities in this space. We have to try to get covered entities to think differently about these, because the landscape has changed, and now the healthcare industry is really on the front end of vulnerability, and we have to be on this fight together. It serves nobody, not the federal government, not a covered entity, not to have these practices in place, because if a healthcare system is going down or someone's PHI is exposed, those are things that are bad and distrust into the healthcare system in a way that I think doesn't promote access and affordable healthcare.
Absolutely. Well, thank you so much for this wonderful session, our first OCR session, and we really appreciate your time.
Yeah, thank you so much.
Okay,
I'm not going to answer it.
go ahead.
Melanie, in 22 years of coming to WEDI, that was the most exciting presentation on privacy and security. Just saying, right? That was awesome.
Thank you.
Also, appreciate your passion and being in your position. I think that's great for the healthcare industry. I do have a kind of a strategic question, and feel free not to answer it.
Mm-hmm.
It seems to be the clinical records are being exposed more and more between health information exchanges. Different use cases are being developed between providers and providers and providers and health plans. Artificial intelligence, machine learning models, whether they're de-identified or not de-identified, whether it's kept within an organization or used within a vendor, there's a lot more chances for private data to be exposed, right? And just wonder strategically how how OCR possibly could be addressing some of that.
Yeah, sorry, I thought I had an AI handout in here, I don't. So yes, so I think this is something that's coming up across our book of business, right? Both in the civil rights context and the privacy context. President of the United States signed an executive order putting forth principles to promote safe use of artificial intelligence. I think in the healthcare space, people like to say, oh, you just want to get rid of artificial intelligence. No, right? There's a lot of value to artificial intelligence, whether it's matching people with clinical trials that they might not otherwise have exposure to in a way that could save their life, or thinking about more cost containment in the delivery of healthcare, which we know in the United States is quite high. And so I think we recognize the value of that. In the HIPAA space, right, there goes Stanley.
He's getting the mic.
Stanley, I'm going to buy you a drink after this. So I think in the HIPAA space, right, we like to remind covered entities that if, in fact, you are using these platforms, that HIPAA still applies. You should have business associate agreements in place, and you should be taking steps under the HIPAA privacy and security rules to protect impermissible use and disclosure. In the space where that is something that we don't full-on regulate, but maybe so-so in like the NIH space, working closely across the department to think about how do we promote more of this compliance, especially as we see the advent of this grow. In the civil rights space, we have a proposed rule out already. We've already put out a proposed rule that says, hey, the law is the law. The law literally just says non-discrimination health programs and activities. That's pretty straightforward. We put out a proposed rule, working on finalizing that proposed rule, something we got a lot of comments on. In the more so, I think as we think about this across the federal government, we're working a lot with the Office of National Coordinator. I think Mickey's either was here already or he's coming. I meet with Mickey every other week. We talk about how does the nexus between what he's doing in information blocking and like HIPAA right of access, for example, and how do you preserve that? And we work very closely with them on their final or proposed rule that they put out. We're also thinking about it in the space of like in a Dobbs environment where we're seeing more laws infiltrate these records, and what does that mean for HIPAA privacy, and what does that mean for information blocking? And we did work with them on guidance earlier this year after we put out our proposed rule and our guidance. And so I think we're in very lockstep in this space. I think, the point is broader as we continue to see more and more use of this data and more interest in the data. One, it's very incumbent upon individuals being more diligent about their own privacy in the first instance, which, kind of sucks, but also is just the truth of the matter. And then two, we as a federal government need to be really succinct in how we think about these issues across the various regulatory streams we have so that we're not stymieing, artificial intelligence or predictive analytics or whatever you want to call them, but we're also protecting people. And we're already seeing this in our civil rights side. We already have open investigations where predictive analytics are being used, algorithms are being used to match like foster parents with kids. And we've seen those systems, for example, say no parents with disabilities. That's illegal, right? And so I just think it's something, it's like new and flashy, but it's not. It's already sort of embedded into our systems that we have to be very diligent about. And also, thank you for the compliment. Yeah.
More compliments. My name is Stephen Lane. I'm a clinical informaticist. Thank you so much. I've actually never met you, seen you present in public. You're a force of nature, so thank you. We all appreciate your service. It's incredible. So I'm on the high tech. I work with Mickey closely, very involved in interoperability issues. You know, your right of access initiative has been super successful for a number of years. You know, clearly puts the fear of penalties into the heart of providers. How, if at all, is that going to shift now with information blocking? I mean, you mentioned you've been working with Mickey, but what does that actually mean for your organization as we go from this 30 days plus 30 days to immediate access? You know, no restriction in the access to data. Are you going to be focusing those efforts that have been being put into right of access into supporting information blocking investigations? And now that we have, you know, rules, or at least an NPRM for providers, how is your office going to get involved in that? And that's the first of a number of questions.
Oh, okay. That's why you started with a compliment, right? Anyways, so yeah, I would say the enforcement within the information blocking, we continue to maintain enforcement over the HIPAA rules, right? So we will continue to maintain enforcement over right of access. We're having pretty regular conversations with our colleagues within the OIG and ONC to make sure that as those cases pop up, and they might be co-populated such that it's both information blocking and a right of access issue, that information be shared and OCR get flagged as soon as possible. Those cases get referred so that we can also simultaneously work on that. You know, we do this, case referrals are not new, right? We have oftentimes, you know, a case where my office, we don't have our criminal jurisdiction, right? So sometimes we might get a HIPAA privacy case that, you know, we can do some with civil liability, but actually it's a very egregious case and we need to refer it to like the FBI or the Department of Justice and make sure that they're tracking it. And so we have a lot of those processes and procedures in place. I think with information blocking, as the rule, you know, it's out there for public comment and it gets finalized. We've had a lot of pretty good conversations about how to do those case referrals, how to share that information across jurisdictions, and I think hopefully we'll get a lot of good comments and public feedback about other ways we might be able to improve that.
Thank you. They said I could get just one more question, so I'm going to jump to my last. So you mentioned about Part 2 data, reproductive health data, and the work that you're doing on that. Those are clearly just two examples of highly sensitive health data. Are there others that your office is planning on prioritizing, be it HIV, adolescent, et cetera, because the industry is just now to the point that we can start looking at how to actually operationalize data segmentation for privacy, and then there's the new aspects of the HCI1 rule for HIPAA restrictions. Where should we be going next?
Yeah, I think it's a good question. So when we write a regulation, it's not something that's just sort of done, I don't know what the saying is, I want to say by the hip or fly by the seat of our pants. It's not done fast. We did do this reg within, I think, a record amount of time because of the kinds of complaints and information we were seeing across the country. And specifically there, right, the legal justification, right, is that the sort of landscape has changed, and this thing that, you know, that NCVHS, which were the original committee of experts that were put in place by HIPAA to inform the Secretary of the United States of the Department of Health and Human Services of how to write a privacy rule. NCVHS, way back when HIPAA was first passed and then the regs were worked on, they flagged this issue, you know, over 20 years ago, right? They said, we think there could be situations where there's sensitive health information that the, you know, patient-provider trust is so important in that relationship where there's going to have to be potential conversations and extra protections. At that time, the privacy rule was written as it was, but there wasn't extra steps taken. Now we have this new shift in the landscape where we're now resetting that. The preamble talks about other information sets. It also, I believe, has comment sets in there, and so we'll be evaluating those comments, and I don't know that we can say more than that. But I think it's something that's certainly more and more of. We're hearing of, you know, whether there's some sort of restriction on a particular type of healthcare, or there's some sort of healthcare where maybe we don't all agree on that healthcare, that data being targeted for different ways in which I don't think providers or patients ever contemplated. I mean, like, I will tell you, like, when I was in a state, they have checkpoints to travel into the state from other law enforcement from other states, where they're asking people, are you going to the state to get an abortion? We have instances where doctors are like worried about flying home to states where the care is not legal, because even though they live in a place like, California is an easy place to pick on, that then they're worried about going home. We have patients who are very concerned about what happens after I leave this clinic, and when I go home, what happens to me? What if I need so we're seeing this in real time happen. These aren't made up things, and so it's, can we as a government work with all of our partners across the country, whether it's in the industry or nonprofits, to figure this out in a way that allows for the provision of medical care? And we're trying.
It's on.
Sorry if I missed this earlier. When you said changes have been made to the security rule to make it align more with most cybersecurity measures, will it just be simply incorporating some of the HICP into the security rule, or what's that looking like?
So we haven't changed the security, so we haven't changed the security rule. We're evaluating the security rule because, it is, the security rule is great. It's 20 years old, it's adaptable, it's technology neutral, and it's adaptable, right? Which means it's been able to continue to be used. I have read in blogs and other things that some people think it's not great, right? That it's not tough enough, it doesn't even require encryption, that having some of these plans, with the Fifth Circuit decision, having these plans in place is enough versus actually using them. So I think there's a range of things we need to evaluate in the security rule. I think that'll be a lot of conversations with the covered entities before we even get to the point of proposing a new rule. But it is something that we're getting a lot of incoming on, and we're planning to start to dive into. But I would anticipate it would take some time, right? And while we were going through that process, we will continue to enforce the current security rule. So it's not as if there will be a gap or a opportunity for bad things to happen, or beyond what normally happens.
Thank you. I'm going to speak now so you can walk out of the room. No, just kidding. I think that's it.
That's it.
In terms of questions. So thank you very much.
Yeah, thank you so much.
Thank you again.
Very good.